Thank you for joining us for another Learning with National Leaders virtual event presented by Sfiteman Cancer Center at Barnes-Jewish Hospital and Washington University School of Medicine in St. Louis. I'm your host, Carol Daniel. October, as you know, is Breast Cancer Awareness Month, so we chose to center tonight's discussion around breast cancer and breast reconstruction. We're going to be focusing tonight on treatments, the importance of screening, and some critical efforts that women, you can take when it comes to prevention. Before we begin our conversation with our panel of experts, let's look at some important statistics when it comes to breast cancer. Breast cancer is the most common new cancer diagnosis among women and the second most common cause of cancer death in the United States. About 1 in 8 U.S. women, about 13%, will develop invasive breast cancer over the course of her lifetime. In 2022, it's estimated that about 30% of newly diagnosed cancers in women will be breast cancers. According to the World Health Organization, breast cancer became the most common cancer globally as of last year, accounting for 12% of all new annual cancer cases worldwide. Additionally, nearly 3,000 new cases of invasive breast cancer are expected to be diagnosed in men in 2022. That's right, while rare, men can also be diagnosed with breast cancer. Death rates have been steady in women under 50 since 2007, but have continued to drop in women over 50. The overall death rate from breast cancer decreased by 1% per year from 2013 to 2018. These decreases are thought to be the result of treatment advances and early detection through screening. So let's introduce our panelists tonight. Joining us are 4 Washington University experts at Sfiteman Cancer Center. We welcome breast cancer surgeon Katherine Glover-Collins. Welcome. Plastic surgeon Terence Myckatyn. Welcome. Radiation oncologist, my friend Lannis Hall. Welcome. Good to see you again. And medical oncologist Ron Bose. Thank you so much. All right, well, a reminder to all of you watching right now, submit your questions right here on the website, and we'll try to get those answers for you throughout the evening. Let me correct that. We're not going to try. We are going to get you answers tonight. So submit your questions now. Dr. Hall, let's start with you, shall we? So we hear so much information about mammograms, breast cancer, and other topics, and do not tune out yet because there's a lot of great information ahead. But if we forget anything else, I know what you're going to say because we talk about it every time I see you. What's the most important thing to keep in mind?
That screening matters, and knowing your risk is essential. So, you know, we talk about screening all the time. We hear that we should begin screening starting at the age of 40. But the truth of the matter is we really need to know our risk. And what that means is by the age of 25, you should have talked to your healthcare provider about, are you average risk or high risk? And what does that mean? That means knowing your family history. And many of us don't share our family history with our primary care physician. So if there's a strong history of breast or ovarian cancer in close relatives, and a close relative would be a first-degree relative like your mother, a sister, or your daughter, or a close relative includes aunts and cousins. If you have multiple relatives with breast or ovarian cancer in your family, but let's go a step further, men with prostate or pancreatic cancer, this all matters because maybe you should be screening before the age of 40. So knowing your risk is important. Are you average or high risk? And then also knowing that you shouldn't screen just every other year or every 3 years, but you've got to be intentional. And when you're screening on an annual basis. And the reason that we do that is the survival is outstanding when we detect breast cancers when they're small and haven't had the opportunity to spread to lymph nodes or distant structures in the body.
So screening, an important tool to finding the cancer early. And here's something that I did not know until preparing for tonight. A woman's 5-year survival rate when breast cancer is caught at the earliest stage. Again, a woman's 5-year survival rate is almost 100%.
Yes, and that's regardless of ethnicity and race. And so that across the board, if you want to have an outcome where it doesn't impact your life for months, we're not giving a recommendation saying you need, so many weeks of treatment, you need chemotherapy. It is really helpful to begin screening and doing it annually because mammograms detect breast cancers 2 to 3 years before you will feel it, on average. And so if we can find stage 1, as you just said, surgery, and you'll find out with our surgeons, is an easier concept with a very small tumor than one that is much larger.
So there are, I am certain, challenges. There are obstacles. What are they to women getting screened?
3, and I would say one of the biggest options for some of our underserved communities is the fact that we have underinsurance and no insurance. So people sometimes don't know where to go to get a mammogram or know the resources that are available. So the one thing I would want to say is that we have a state program called Show Me Healthy Women. And that program is tax funded, so our tax dollars at work. But not only does it offer mammogram screenings for free for women who qualify, and for a family of 4, that would be over $55,000 to $60,000. So that means many women would qualify. But if you detect a breast cancer, you get rolled into an insurance called Medicaid. And Medicaid is a full insurance program so that your transportation is paid for, your chemotherapy, your radiation, your surgery, your prescriptions, so that you're not just getting a screening, but you're also able to get treatment.
Are there screening guidelines we need to talk about?
Yes, there are. And then we got to get to some important people.
We're going to bring them all in, yes.
Yes, and we follow the NCCN screening guidelines because we are part of the National Comprehensive Cancer Network. What that means is starting at the age of 21 to 39, screening should occur every 3 years, meaning going to a healthcare provider and having them do a clinical breast exam. If you are average risk, you begin screening starting at the age of 40, along with seeing a healthcare provider annually. And then the whole concept of self-breast awareness, knowing your breast, knowing if there's a change, to immediately contacting your healthcare provider.
All right,
Okay.
She wanted me to, and I was going to do it anyway. Bring in the other panelist, Dr. Glover-Collins. It's good to see you again. For those who haven't been screened for breast cancer, are there symptoms we need to discuss tonight?
Yes. Obviously, we know about the mass. Everybody is looking for a mass, but the one thing I should say about masses that tend to that result in a cancer diagnosis are usually not painful. So pain is usually a late symptom of breast cancer when it's growing into something like your chest wall or growing out of the skin. So if you feel a lump, you should get that evaluated. Nipple discharge. Usually this is discharge that's going to come out on its own. It can be bloody or it can be not bloody. But nipple discharge should be evaluated. And then there are those skin changes. You might notice that the skin is becoming roughened in texture. You might notice redness, dimpling of the skin, your nipple is starting to change. All of these are symptoms that should be evaluated.
There is something called the 3D mammography, and we understand that all healthcare plans in Missouri and Illinois now cover this. Why is it special?
Well, the 3D mammogram helps women that have these dense breasts and people that are considered higher risk, because a mammogram is thought to traditionally have been kind of not useful in anyone under the age of 40. But yet we're asking that some women get screened before they're 40. So the 3D mammogram helps us to see these small masses in dense breasts and just helps us to catch more. And it's way better than a 2D mammogram. So it's very important that we get them.
And talk too about the concept of where. Why is where you get your mammogram important?
So You can get a mammogram anywhere.
Right.
But if you get a mammogram at a reputable breast health center, then you're getting a mammogram by someone who's been trained to look at mammograms. And that's all they do year in, year out. And so you're likely to get a very reliable test result from that. Also, it's important that you get it at the same place every year.
Oh.
Don't bounce around, because then they have to go and find your mammograms from 10 different places to compare them, because it's the changes from year to year that alert us to something going on. So every year, same place, and at a reputable breast health center.
Thank you so much. Dr. Bose, your turn. I know as excited as Dr. Hall gets about talking about screening and getting in early, you're about to get excited talking about research and the advances. I do know this. So with many types of cancers, treatment options for breast cancers, as we know, have greatly improved over the years. Talk about recent advances that come to mind.
Sure. There's been a number of new drugs, and there's also some tests that we do once a breast cancer has been diagnosed that help us guide patients' therapy. So there's a category of drugs called CDK inhibitors. These are oral pills that women take. It's primarily been used with patients with metastatic breast cancer, but we've been even using them with patients with early stage breast cancer that have had surgery. Drugs in this group are Kisqali, Verzenio, Ibrance. You'll probably see ads for them saying living longer with metastatic breast cancer. So that's what they're talking about. There's antibody drugs that we use in breast cancer treatment. The first antibody drug, called Herceptin, came out 25 years ago, but new innovations on antibody drugs are continuing to emerge, and we're making use of them for a broader range of breast cancer patients. Finally, there's specific testing that we can do to determine what is the best treatment for an individual cancer. There's gene panels, DNA sequencing that we can use to say, okay, should this patient get chemotherapy for this breast cancer? Or should a patient who has DCIS, stage 0 breast cancer, consider radiation as part of their treatment? So there's a lot of new innovations that have been coming around, and it's really an exciting time with all the things we can offer.
What is exciting in clinical advances that is noteworthy that we can discuss tonight? All
of these drugs, there's ongoing clinical trials. Sfiteman Cancer Center is participating in a large number of clinical trials, both trials that are occurring at many places in the country, as well as trials that are developed here using science that comes out of Washington University. So the clinical trials are a big part of what we do, as well as the standard treatments that we are making use of, advances all across the country and come from all over the world.
What makes you hopeful?
We continue to see improvement for women with breast cancer. Prognosis continues to improve year after year, and I don't see any end in sight on that. We're going to continue to do better, and there's so much that we can offer patients now.
Do not forget that you can submit a question, and we'll get those answered for you tonight. So let's turn now to oh, we do have a question. Oh, I apologize. Should someone who has had a mastectomy have a PET scan to see if cancer is in other parts of their body? Anybody can take that.
We generally, a PET scan could be considered, but in many cases that may be a little bit overkill. We might want to just start with a CT scan. That will cover a lot of the body. The CT scan is a lower cost, maybe a little bit lower radiation exposure, and we can probably get it very quickly. I think it's a question to ask your doctor if you're facing a breast cancer diagnosis and see what they say. Most situations, we would not generally go to a PET scan.
We talked about men getting breast cancer. It is rare. Another question from a viewer: how frequently should men be screened for breast cancer? Dr. Hall?
Well, right now we don't have a formal screening for men for breast cancer, and the reason is that although about 2,800 men will be diagnosed this year, we have 287,000 women, so that's like 1%. And the people who should be concerned about male breast cancer are people who we are worried may have a mutation or a change in a gene. And so those men should be on heightened alert. And that, you might say, well, how would I know if I have a change in a gene? So if you have a family history of breast or ovarian cancer, or a sister or mother or relative who has been tested and they've been found to have a change in a gene, that's when it's important to talk to your healthcare provider about, is there anything extra I should be doing other than breast self-awareness? And typically we would talk about breast self-awareness because a lot of people men don't think they have breast tissue, but they do. And it's just not nearly as much as women because it's not developed.
All right, thank you so much. And again, we will get answers to your questions. Feel free to submit them at the website. So let us turn our attention to another important topic, breast reconstruction. We want to start off with some facts, as we always do. Surgery is a standard treatment strategy for most patients with breast cancer. Breast reconstruction is commonly offered to women receiving a mastectomy, and women are increasingly choosing to undergo breast reconstruction. Surgical options include mastectomy, where the entire breast is removed, and lumpectomy or segmental mastectomy, where a portion of the breast is removed, followed by radiation. Mastectomy is chosen or recommended for about 50% of women in the U.S. with breast cancer. Thank you for joining us. Let's bring him in, the only person you haven't heard from yet, Dr. Myckatyn. Can you share some of the surgical options that women with breast cancer consider?
Yeah, absolutely. Thank you for that. So, when we consider breast reconstruction, there are several decisions that need to be made. And, when we look at these decisions, we look at them both in the context of risk for our patients, working the reconstruction around other oncologic care, such as chemotherapy, immunotherapy, radiation therapy. But the interesting thing about breast reconstruction is it's not just a medical decision, it is somewhat of a biopsychosocial or emotional decision as well. And so we talk about decisions that are risk and preference concordant when we do this type of work. And so the first question really is mastectomy versus lumpectomy. And so I noticed from your slide that we talked about reconstruction for mastectomy, but we can also reconstruct for lumpectomy defects as well. The second thing then would be whether we choose to do the reconstruction immediately, meaning that we start the process at the time of the mastectomy or lumpectomy, or if we initiate the reconstructive process, whether that be weeks, months, days, years later. And then when we choose to reconstruct, there are sort of two broad categories. So we could reconstruct using implants, or we can reconstruct using your own tissue, which in plastic surgery parlance means that we are reconstructing with flaps. That means that we are transferring tissue with its own blood supply from elsewhere in the body, such as the abdomen or the back or the legs, to the breasts for reconstruction. I would point out that most reconstruction is done in steps. So when we've done this research, we've seen that women on average need 3.6 surgeries in the first 2 years to complete their reconstruction. And that's looking at tens of thousands of women who've undergone these processes. One of the viewers had a question, which was whether one can reconstruct immediately at the time of the mastectomy. And yeah, absolutely. Often it doesn't end there though. That's usually the first step. The majority of the time, those women are coming back for more touch-up procedures later.
And you mentioned the emotional aspect of that. I would imagine hearing that I have to have 3 surgeries, that would sit me back in my chair because I've just gone through reconstruction, for instance, and now I have to go through even more.
Yeah, so I agree with you. And oftentimes when I address that with patients, I say, I realize that may sound disconcerting or shocking to you that there's this many surgeries, so let me explain why that is. So, with reconstruction, I think, of course, as a plastic surgeon, we are super sensitive to the fact that we are, while important, we're not the most important thing. Obviously we want to make sure that breast cancer is adequately being treated. So part of the reason that we're less aggressive with the initial reconstruction is because we want to make sure that the other therapies and things are adequately undertaken. Another factor, honestly, is that the reconstruction and the shape of the reconstruction changes over time, the effects of gravity and swelling and all these types of things. And so we often have to sort of wait and see where things settle before we make other alterations. And I do think also that certain patients are more or less particular about the appearance of a reconstruction. And so fortunately, insurance does cover, there's the Women's Health Protection Act of 1997, which is a federal law which protects a woman's right to have reconstruction, revision procedures, which are touch-ups, or management of complications such as infections, and also the management of lymphedema.
You did mention implants, saline or silicone. What is the difference? Is recovery a difference, or is just appearance? Talk about that.
Yeah, so there is really no difference in terms of the recovery. So a breast implant can be filled with salt water, which is a saline implant, and it can be filled with silicone gel, which is a silicone device. The shells, which is the surface that contacts the patient, is very similar between the two. Generally speaking, saline implants feel a little less natural, and when research has been done looking at patient-reported outcomes, so how they feel about it, women tend to favor silicone gel implants, but they definitely have their issues. When they leak, and all breast implants, if you have them long enough, will eventually fail. And so when they leak, or if they leak, you may not be able to tell with a silicone implant. So it does require maintenance. It requires ultrasounds or MRIs frequently to check them to make sure they're okay. Breast implants can also become firmer with scar tissue forming around them. So an alternative strategy often is to use your own tissue for reconstruction.
I know you talk to your patients about the recovery process. Can you tell us about that tonight?
Sure. So I do think, like the procedures, that can really vary quite a bit. An immediate reconstruction where a woman is having breast implant placed, typically we tell our patients that those recoveries are 3 to 6 weeks. Typically drainage tubes are there for about 10 to 14 days. These days, most women get to go home the same day. They rarely spend the night in the hospital from the initial phase. The thing that we're really careful and watching for is an infection in that first couple months, really, after the mastectomy and the reconstruction. And then touch-up procedures are typically done after that. In cases where there's no chemotherapy or radiation, we typically do those touch-up procedures 4 or 5 months later. But with chemotherapy, they're usually 8 or 9 months later. With radiation, additionally, they can be a year or more later on. Reconstruction with your own tissue is a greater undertaking. Those patients usually require about 6 weeks for recovery because they're recovering both at their breast site as well as the site that we removed the tissue from, called the donor site.
We do have more questions we're going to get to, and then we are going to bring in Dr. Glover-Collins again as a breast surgeon to talk to her. You said infection is one of the risks. Are there others quickly before we take more questions?
Sure. Well, for breast implants, the early issues are infections and wounds, and the late issues are implant leaks and scar tissue or capsular contracture. For reconstruction with your own tissue, really the larger issue is issues with wounds and recovery relating to where we took the tissue from. Rarely there can also be issues with the actual take of the tissue that we transferred.
All right, let us get to some more questions. Will you be discussing revisions or to previous reconstruction surgeries? Or can you?
Choice of option when having. Yeah, I mean, we can certainly. I can certainly talk about revisions as much as you would like.
Yes, that happens?
Oh yeah, absolutely.
Yes.
So, I would say that we sort of describe our patients who undergo breast reconstruction as kind of going through a journey, and I think that there are the early components of the journey, which is the immediate reconstruction, but then whether that be because of issues with their implant or perhaps they've changed their mind and they would like to transfer from an implant to their own tissue. or just from gravity and aging, honestly, or new technologies that become available, patients do choose to revise their reconstruction. So that's an option. The other group of women is, unfortunately, there are pockets in the United States still where reconstruction isn't as broadly offered for a variety of reasons. And certainly those women who maybe were told they couldn't have a reconstruction often can. So we see those women as well.
Can you give me one reason in a region in the country why it is not broadly offered? Is that just a lack of surgeons?
Yeah, it could be due to a lack of plastic surgeons. That can be certainly one. Perhaps philosophy of the treating center. That's less common now. It can be related, unfortunately, to issues with resources and insurance and those types of inequities as well.
Here's another question. What are some choices or options when not having reconstruction or having a type of fat reconstruction, say scarring or ripples? What are some of the other options?
Yeah, so there is certainly the option not to reconstruct, and the sort of term that's being used a lot is sort of to go flat, or an aesthetic flat closure is often used in social media as well to describe that. And what that means is that once the breast tissue is removed, rather than reconstructing with your own tissue or reconstructing with a breast implant, the operating team tries to do a nice job in making sure that the skin that's closed is flat and relatively smooth. And there are also instances where if a woman has chosen not to have a mastectomy, doesn't necessarily want to use an implant or a more extensive procedure where fat can be, with liposuction or sucking out fat, can then be transferred into certain sites to try to soften them, not necessarily to have a breast reconstruction, but just to try to even out or smoothen out an area after a mastectomy.
Is it possible that a woman doesn't have enough fat to do that?
As a plastic surgeon, I always feel like I can find fat. However, I would say
that was the line of the day.
but I would say certainly there are women who are thin, and frankly, removing fat can be it can cause some irregularities in where we remove the fat from, and so we prefer not to. And so there are cases where women are certainly better cases for some types of reconstruction than others. Yeah.
After reconstruction, do you need to get mammograms? Dr. Hall, our screening, are we saying no? Okay, here's another question. Our viewer had a lumpectomy with radiation in 2008, I believe that was. They want an implant, but they keep getting turned down. What are the recommendations or the advice?
Yeah, so I will say that placing a breast implant in a radiated field is always a complex issue, and the rates of complications with those tend to be pretty high. So early on with wounds healing, later on with progression of something called capsular contracture. So in general, if the patient has already received radiation, our preference is to use their own tissue when we can to reconstruct. The alternative is sometimes we can get a nice match between the two sides by actually operating on the healthy breast to match it to the one that has been radiated. So it depends a little bit on the situation.
And one of our viewers is asking, if I need surgery, medical oncology and radiation oncology, how is that care coordinated? Do you guys talk to one another about my care? I'm glad they asked this, because that's an honest question.
And I think it's so important. Years ago, we learned that a multidisciplinary breast team is key to giving the best care to our patients. So that means having a team of doctors that works together, sometimes sees you on the same day, but if they don't, have a conversation about you in their tumor conference, so everyone is on the same page about the best treatment strategy for you, what your staging workup should be, when chemotherapy, if you need it, should come before or after, what your surgery looks like, your plastic surgeon and your radiation oncologist ideally seeing you before your treatment begins. And, you know, Dr. Myckatyn has laid out a number of beautiful ways in which he can do reconstruction, and it matters when the radiation occurs during this reconstruction. That means we need to have some conversations about what might be best based on the radiation program that I'm thinking about. So the surgeon, the medical oncologist, the plastic surgeon, and radiation oncologist all talking to each other is important.
Dr. Myckatyn, get ready to blush. A viewer says you did their surgery. It took several surgeries, but you wanted to be certain that they were happy with their appearance. You are described as a great, compassionate doctor.
Thank you so much.
That's wonderful
The
to
check
see.
is in the mail.
There you go.
No, I thank you very much. I appreciate it.
Talk about your mindset, though, wanting the appearance, that they be happy with the appearance. Talk about your mindset there.
Yeah, I do think that it's always a difficult balancing act between trying to protect our patients, on the one hand, from, their disease, from the treatments that we know they need, and then also from making poor decisions. And so we definitely want patients to be happy and try to deliver as much as we can. But, the reason that we do this all the time and that we're passionate about our work is because we also, I think, have gained some foresight into, these are the steps that are going to happen. We can expect that a patient may be in one spot today, but a year and a half from now, this is where things are going to be. And we need to make sure that we have sort of the foresight and the game plan and prognosticate as best we can how we can get them the best reasonable outcome at the end of the day, knowing they may need radiation, knowing they may need chemotherapy, a re-excision, or whatever that may be. So I think that, and I think the reality is there's such extreme diversity in our patients, their backgrounds, the way they present, their goals, what happens along their cancer pathway, their reconstructive pathway, that I really do think that you have to be somewhat nuanced about it, sensitive to it, and I think try to deliver options whenever you can that are going to keep them happy and safe.
We appreciate that. Dr. Glover-Collins, I promised I'd bring you back in. You are a breast cancer surgeon. Talk about what these discussions are like with patients.
Well, I always try to have my patients first come in with a family member because it's going to be a lot of information up front, and we're going to try to outline a game plan. And so that second set of ears is really helpful to reiterate what was said because they're going to forget most of it. But for me, I try to first discuss their diagnosis and discuss their prognosis. I kind of go through all the medical jargon to help make sure that they understand what it is that they're dealing with. And most patients are relieved just to find out, I don't have that stage 4 or that I don't have stage 3, but it's at a treatable stage that we can get good outcomes. And then I try to educate them to say, we do have a choice between lumpectomy and mastectomy. Very rarely do I have to say you have to have a mastectomy.
Okay.
So most women are choosing mastectomy when that is the surgery that has been performed. And we just try to make sure that we understand what the patient wants, help them to understand what the prognosis is, what their survival is going to be good regardless of what we do when we catch it early, and then try to walk them through and let them know that every treatment plan that we're making is based off of their particular cancer, and that their journey might not be the same as their friend or their neighbor next door or their church member that had it.
Right.
And that's where we try to go with that.
Well, you will be very proud of me that my mother had breast cancer about 4 years ago and had a lumpectomy. And during one of the meetings with the doctor, I went in with my dad. Now, my father felt like he didn't need me to go in there, but I didn't take no for an answer. So I went in anyway with a big fat notebook and a pen, and I was, I knew that he would not know what to ask. I just knew that. So not just spouses, but if your mom's going through it, you may need to go with your dad because he definitely needed me there. And you did mention that there are other options other than surgery.
Yes, I mean, most most cancers are going to end in a surgery, but for patients that are older, we have clinical trials looking at just giving medications, seeing if we can keep the cancer in check. And for right now, all of those options are basically on a clinical trial.
You know, options is plural. So there are a lot of things that women and their loved ones are deciding. Dr. Hall, this is difficult. These are difficult decisions, and I know you all know that. How does Sfiteman help women walk through these difficult decisions?
We have our multidisciplinary breast team, and we try to have a multidisciplinary team at multiple satellites so they're easy for you to navigate in terms of transportation. Everyone doesn't have to travel in to our main campus, but we have 5 satellites in which we have breast surgeons as well as medical and radiation oncologists who are dedicated to making sure that not only do you have a social worker, sometimes a dietitian, but people who can help you to get your care in a timely fashion. So that's one, but we also work closely with breast cancer advocacy groups, and that's when they can really be helpful. These are an army of women who are survivors and dedicated to sometimes budding, coming in and being that other set of ears if you don't have anyone to come with you. And so the Breakfast Club has a buddy program, and we have pink ribbon girls knowing that sometimes you can't cook for your family, but they have meals that come every day to your home while you're getting treatment. So you have a support network of women who are really there for you, not to mention the finances. Sometimes you can't work while you're going through some of the treatment, and then you have Gateway to Hope that will pay for your mortgage and car insurance during your care. Many people don't know they have these resources available, but I just want to remind people where we've come from. 30 years ago, we used to do mastectomies that included taking the pectoral muscle. So you couldn't hold a baby or pick up a bag of groceries, but through clinical trials, we found we did not have to do that. We then had trials that compared mastectomy to lumpectomy and radiation, found there was no difference in outcome. So if you wanted to preserve your breast, then you were not in any way shortchanging your overall lifespan or increasing your risk of recurrence. Now with radiation, we've gone from 6 weeks to giving 3 weeks to many times I give 5 days, and on clinical trial, we're looking at 5 days versus 1 day. The research and the ability to think about alternative therapies, we have over 500 clinical trials at Sfiteman. And so just the concept of speaking to your multidisciplinary team about what are my options based on what you want, I think we can offer many options, but at the same time, always giving guideline-directed care too.
I will say that another way in which I know that Sfiteman helps is by being in the community.
Yeah. Because
I have seen, certainly I know all 4 of you are out, but I've seen at least 2 of these doctors at various events talking to women about what Sfiteman does and what we should do as women. So that is another way in which Sfiteman helps, is that the physicians themselves are out in the community talking about what we can do for ourselves and what Sfiteman does for us. Dr. Bose, I want to give you a bit of a last word here. If there's anything you would like to add, but also tell us what is one of those important things, an important take-home message for us.
So one thing I'd like to add is with regard to medications for breast cancer, we have a wide range of options. There's endocrine therapy, which are medications that work on estrogen and how estrogen works on cancer cells. We have targeted therapies. Some are IV, some are oral. Chemotherapy is used, but we use it much more selectively these days. So what you may have heard from a patient 20 or 30 years ago, as Dr. Hall was saying, has really changed. I think in terms of bottom line things, the things that people should come away with from this conversation is early detection is key. Educate yourself about breast cancer, about your family history, what you can do about risk factors for yourself. And then if you're diagnosed with breast cancer, work with your doctors to get the best treatments.
All right, there's a competition going on now. Somebody complimented our plastic surgeon, so now Dr. Glover-Collins, one of your patients, is chiming in. She's my breast surgeon. I'm adding tone to this. She is a great surgeon and a doctor who explains everything she can in order to help. And that's not a given that a doctor explains everything.
Yeah. Yes.
Am I right? You do.
This is
Why
true.
do you explain everything?
Because I think it's important for patients to know and have an idea of what's going to happen. I don't ever want a patient to walk out of my office and say, I didn't know that I was going to need both surgery, radiation, and chemo, and then come back and have to take these pills for 5 years. And so that's why I want patients to come with family members, and I want them to know that there's a game plan. It might change and tweak as I send you to different doctors, send you to the medical oncologist, send you to the radiation oncologist. But there's a generalized game plan, and it's tailored to you. And I just think it's very important.
I like that word, tailored. I like that. Do they not have collagen implants? I asked about silicone and...
Not for breasts.
Okay,
Yeah.
not for breast to our viewer. Question, who orders a CT scan or additional testing, the primary physician or the oncologist?
Most of the time, the oncologist will take over there. I trained in internal medicine before going into medical oncology, and that's true for all medical oncologists. So we're used to coordinating with the primary care physicians. We'll work with them to make sure everything gets done, but the oncologists take over once the breast cancer diagnosis has been made.
Occasionally, the breast surgeon will also, our goal is to make sure that there aren't any breaks in care and no barriers. So if we see that you're going to need some imaging, we'll often talk to the medical oncologist and say, hey, you think you're going to need this? And we'll order it so that in the time that it takes to get them referred, that we can continue to gather the information we need.
Another question from a viewer, is there any data? Are there guidelines available for breast cancer incidence rates or development in males transitioning to female or vice versa?
So there's not formal guidelines, but I will say there have been some studies looking at transitioning from male to female, and in that transition, you will have a reconstruction, but some of the hormones that are used, the concern was, will that increase the risk of developing breast cancer? So there's breast cancer awareness issues that I think are instructed. And Dr. Myckatyn, is there anything else that you would add to that?
Yeah, occasionally we will have patients who are transitioning from female to male who also have a BRCA or ATM mutation.
Yeah.
And in those instances, we do actually involve one of our surgical, because so most of the time the plastic surgeon is exclusively doing that procedure. However, if that is the case, then we do work with our surgical oncologist, and that particular, we call it a chest masculinization procedure, is done more similarly to a mastectomy rather than a standard masculinization procedure.
Excellent. Is there any research that shows that taking a daily baby aspirin can prevent cancer or a reoccurrence of cancer?
So there's been clinical trials looking at aspirin. There was a lot of interest in this probably 20 years ago, particularly around aspirin and colon cancer. I don't think there's anything convincing with regard to aspirin and breast cancer. A recent clinical trial did not show any benefit for aspirin use.
That's right.
Okay, here's another question. What is the success or complication rate with is that fat lap? I can't even see that.
Latissimus flap.
Thank you. Yeah, with implants being used to replace current implants that has to go due to, and my surgeon, are you going to take over here?
I'm happy to.
Yes, thank you so much. Let me just admit that I forgot my glasses tonight, so I'm straining to see.
So the question is, what is the success or complication rate of what is called the latissimus flap? So that's when skin, fat, and muscle is transferred from the back to the front to reconstruct the breast. So when that is used with a breast implant, and it's being used to replace a current implant that has to go due to capsular contracture. So capsular contracture is one of the two main reasons that implants will fail late, leak, and then capsular contracture is when thick scar tissue forms and distorts the implant. So I think that the success rate is higher if you use the latissimus flap with the implant rather than just an implant. We know from quite a bit of research that if somebody has developed a capsular contracture, whether it be in radiation or not in radiation for any reason, and then we place just another breast implant in, the chance that a new capsular contracture eventually forms is pretty high, like almost 50%. So we try to do something to reduce that, and the latissimus flap sort of changes the environment in order to reduce that risk.
No, thank you for that. Here's another question. We have two more. I heard on the news certain implants can cause cancer. Is this all implants or only certain ones? Is there more than one surgery also involved with implants versus your own tissue? That's a good question.
Yeah,
they're all good. That's a good question.
Yeah, sure. There's two there. So the first question is, there is a type of lymphoma called breast implant-associated anaplastic large cell lymphoma. There is about 1,300 cases worldwide, about 400 in the United States. I think 36 deaths worldwide have been reported. Those are associated with textured breast implants. The main culprit has actually been voluntarily pulled off the market about 2.5 years ago. But for context, the rate of that is about 1 in 2,000 patients with that device. The second, now they're in extremely rare cases. We also know that something called the diffuse large B-cell lymphoma and a squamous cell carcinoma are also known to arise from breast implant capsules, and their rates are like 0.01%. In terms of the other question, is there more than one surgery involved with implants versus your own tissue? Both ways. There is more than one surgery typically. So you're not saving yourself too much in the way of surgery. Most surgeries will require a revision surgery. If you'd like, I can answer the last one.
Because he knows I can't see. He is a compassionate doctor. This is about nipple reconstruction, and one has failed due to infection. And you can take the rest of that.
Yeah, it depends in that case whether that failed nipple reconstruction is over an implant or your own tissue. Typically, though, we would remove the scar tissue that was associated with that and the fat necrosis underneath. And honestly, in most cases, I would recommend what's called a 3-dimensional tattoo at that point, rather than trying to reconstruct that again.
What a great discussion. Thank you so much. That wraps up tonight's discussion. I want to thank our panelists for taking time to join us tonight. Dr. Katherine Glover-Collins, thank you so much. Dr. Terence Myckatyn, thank you. Dr. Lannis Hall, always a pleasure. Dr. Ron Bose, we appreciate you so much. And thank you for being with us tonight. Make sure you sign up for our next Sfiteman Learning with National Leaders discussion. Our panelists will join us to talk more about brain cancer. You can start signing up for that event tomorrow by coming right back here to this website. Meanwhile, I invite you to visit yourdiseaserisk.com. You'll learn about your risk of 12 cancers and other chronic diseases, and you'll get personalized tips for preventing them. I've done that myself. As always, thanks for joining us. Have a great evening.